Dr. Balan.
Thank you, Joe. So in this portion of the talk, I want to kind of marry what we talked about just a moment ago to dealing with some of the complications that happen. We've just seen the data showing that TAVR is safe and effective, but that doesn't mean that there aren't complications. And really what I want to get into is talking a little bit about where TAVR is going from here. Now that we know that it is a safe and effective treatment for severe aortic stenosis, TAVR is going to diffuse out of the quaternary care centers, out of the academic centers, and really disperse out into the community. And there are good reasons for that to happen, and we'll talk about those reasons. But we need to be prepared. How do we deal with the complications? Because although that complication rate is low, when there are complications, they can be quite significant, and one needs significant hemodynamic support. So what are some of the complications that can occur with TAVR? Perforation of the heart, RV or LV. RV perforations are a little simpler. LV perforations typically require opening the chest. Obviously, pericardial effusions, tamponade, that can be dealt with percutaneously, but in the meantime, one occasionally does need the hemodynamic support to get the patient through. Probably the most feared complication is annular rupture. After over 1,000 cases, I've seen 2 of these. It's usually devastating. There oftentimes is no bailout for annular rupture. Coronary obstruction. This can be an issue both from the standpoint of the native leaflets folding up and potentially blocking access to the coronaries, or embolization of calcium from the native valve down the coronaries. We have seen a few of these MIs, and we'll look at a case as we go through this talk. Go ahead.
No, go ahead. I just thinking to myself.
Valve embolization, that is a also relatively rare complication. If it embolizes forward into the aorta, that can be dealt with. As long as it maintains its orientation, you can actually just deploy it somewhere in the aorta and keep moving and put a second valve in. Embolization into the ventricle, which is what you see on the right there, is a whole other story. That needs to be dealt with surgically. So this is a patient that had to go on pump and went to the OR. That valve was removed from the ventricle and a surgical valve placed. Severe paravalvular regurgitation, that is also something that can cause acute severe hemodynamic instability and is difficult to deal with. Aortic disruptions, aortic dissections have been seen, and that too will require surgical intervention and hemodynamic support. Major vascular injury, disruption of the iliofemoral system and so forth can also create major problems, as well as hemorrhage. Now, in terms of the background here, in 2012, based on the original PARTNER trial and pivotal trial, core valve pivotal trial data, when the FDA provided approval for TAVR, the Centers for Medicaid and Medicare Services provided this national coverage decision in 2012 regarding coverage for TAVR, payment for TAVR. And the essence of this was that a hospital must have substantial experience with both percutaneous interventions and surgical interventions in order to undertake a TAVR program. They required that hospitals have 50 or more surgical AVRs per year and 400 or more percutaneous coronary interventions per year. And that heart team, from the standpoint of the individual interventional cardiologist and surgeon, the surgeon would have to have greater than 100 lifetime AVRs, and the interventional cardiologist greater than 100 left-sided structural heart procedures. These were relatively high bars. There are few centers and few operators at that time that had these kinds of numbers. So it was primarily the large academic centers, the quaternary care centers, that were able to meet the requirements of the original national coverage decision. And we did see a steady growth of TAVR in this era of the 2012 NCD, but it topped out at about 500 to 600 centers that were performing TAVR. And we saw a lot of TAVRs performed by those centers. You can see by 2016, the number of TAVRs was approaching 35,000.
Wow.
Now, does this mean that TAVR should stay with those highly experienced 500 to 600 sites around the country that do a lot of this? People looked into this. This is some data from John Carroll and the TVT database, there is a registry. Part of the NCD requirement was if an institution is going to be doing TAVR, they must report all of their data, all of the commercial cases are reported to the TVT registry. And from that database, we've been able to see what have we been doing? Has it been effective? Are we doing this safely? Are we doing this well? So it's an extraordinarily rich bank of data from which we've been able to study our outcomes. And one of the things that was looked at by John Carroll was the relationship between procedure volume and outcome. The presumption of the national coverage decision was that volume was a key determinant for outcomes in the setting of TAVR. So the purpose of the study was to examine that hypothesis, and luckily with this TVT registry, they were able to do this with a very large population. Nearly 43,000 patients were studied from the registry. And here's what they found. There is a very clear learning curve to this. The inflection point comes at about 200 cases. You really see that downturn in mortality rates once a center gets beyond about that 200th case. Like anything else in life, learning a bike, you have to fall sometimes in order to really learn how to ride a bike well. And this very elegant data using this large TVT registry shows us that it's about 200 cases that you need to get to that point where now you're zipping along on that bike and doing really, really well and achieving the kinds of outcomes, mortality rates less than 1 to 2%. Those can be achieved once you have that level of experience. Now, again, that would lead a lot of people to say, well, then TAVR should be restricted only to those centers that have very large volume. Our center, we've done over 2,500 cases, I think, at this point. We're probably approaching 3,000 cases. I've lost count. Not every center can have that level of experience, nor can every patient travel from wherever they are to the Texas Medical Center to come have their TAVR. There is a serious issue regarding access to care here, okay? When you look at the United States map here, you can still see there are a lot more states that have more surgical centers than they do TAVR-capable centers. And Texas is among those states here. And this was some very interesting data looking at less well-served populations. This was from an article that came out late May, early June of this year in JACC Interventions, looking at rates of TAVR among traditionally underserved populations, African Americans, Hispanics, socioeconomically disadvantaged groups. While you see the growth in the number of TAVR centers in that dotted line at the top, the rates over time of TAVR availability for these minority groups doesn't budge. The disease does not discriminate. The rates of severe aortic stenosis among African Americans, Hispanics, whites, Asians, it's all the same. It's 7% of the population over 65. The disease does not discriminate. Yet access to care does appear to be differential for these patients. So with that in mind, CMS released a new national coverage decision in early June of this year, trying to improve access to care. And this is, of course, in the background of all of the data we've seen showing us that TAVR is a tremendously safe and effective technology. We need to make this technology more available to more patients. And that's really the gist of the new national coverage decision. Rather than requiring 50 or more surgical AVRs per year, that requirement is now 50 or more open heart procedures. So any open heart procedures, CABs, now count towards qualification to be a TAVR site. And the PCI requirement has gone from 400 to now 300 per year. So in sum, this new national coverage decision reduces the volume requirements. There are still substantial volume requirements, certainly from the interventional side, in order to maintain that quality piece so that we meet that volume outcome relationship that we know exists. We have to maintain the quality, we want experienced operators, but we want this to diffuse into the community so that more people have the opportunity to access this transformational technology. Of course, what that means is we're now going to have some of these potentially devastating complications, not just in the academic quaternary care centers where we've got every machine, every tool, everyone, all hands on deck. Now it's going to be happening in more of the community hospitals around the country, and we need to be prepared for that. It's still going to be a partnership between CT surgery and interventional cardiology. The CMS requirement still requires that the procedure be done in a combined fashion between the two disciplines. However, the question isn't really about surgical backup. When something truly does go wrong, before you can get to a surgical fix, you've got to have some form of support. And that's where ECMO really comes in. So when we think about it from the ECMO standpoint, what are our traditional indications for ECMO? Your goal with ECMO is typically a bridge to recovery or to some other form of life-saving technology, whether transplantation or destination therapy with a VAD. In the TAVR situation, when things go wrong, it's going to happen very fast, and your only goal here is to get yourself a bridge to something. We'll figure out what that something is once we get there. Okay. Now, in terms of access, with the traditional transfemoral TAVR, this is a picture of a case from a few years ago. And part of the reason I put this in, you see the large sheath over there on the patient's right near my hands. On the contralateral side, what you see is a 6 French sheath in the left femoral artery and a 5 French sheath in the left femoral vein. The arterial sheath is being used for the pigtail, which allows us to monitor and inject during the case, allows us to see the valve as we're deploying it. That 5 French sheath, though, is purely there for bailout. If something does go wrong, you can take those 2 access points and get yourself onto VA ECMO very, very quickly. So here's a case example. This was a case from earlier this year. Valve deployment goes beautifully, perfect looking valve. However, we have a problem. Anyone see what the problem is here?
Yeah, your coronary is obstructed.
Yeah, there's no right coronary now. You see the left main, but the right coronary, trust me, she did have a right coronary before this. And we saw it on the monitor as well. Within a few minutes, you began to see the ST elevations, and you can see the pressure is beginning to drop. She'd started the case with a pressure in the 140s. Now we're down about 80 over 40. Took us a little while to engage this, but this was a coronary embolization. Basically, calcium from the valve. It's like a shark tooth-like shard of calcium that has gone down this somewhat high anterior right coronary artery. This was a case where, I didn't think about coronary protection at all, because that right coronary is about 19 millimeters above the plane of the annulus. You can see it's well above even the frame of the valve. Likely what happened here was a chunk of calcium from the valve itself flew off and lodged itself into the ostium of the right coronary. So luckily we were able to engage it, get a wire down, stent, and escape the situation with a patent right coronary artery. But of course, you can see we did all of this. You can see the cannula there in the right atrium. So we were on VA ECMO from the femoral approach.
Oh, so you went ahead and put this patient on ECMO
Of
to
course.
do this.
That pressure of 80 over 40 was when we realized what was going on. It went south from there. I mean,
Clearly.
we were 60 over PAL within minutes. And that's the point where we go on pump, then start fishing for that coronary. And as I said, this was a high anterior takeoff of that right. This was not easy to engage. It took me 3 different guide catheters to get an engagement that would allow me to get a wire down that. You can't spend 30 minutes at 60 over PAL and expect the patient to do well. You're going to be in multi-organ failure. ECMO gives us that bailout whereby I can support the patient, get them through this, give me enough time to fix the underlying problem, and then bail the patient out. So in terms of your most common bailout strategy in terms of VA ECMO, it's going to be FEM-FEM VA ECMO. And this is traditionally what that looks like. This is just a stock picture that Joe provided me of the arterial return cannula and the venous drainage cannula there. As I said, typically we prepare for that kind of access at the start of the case. With every TAVR, I like to have a bailout vein, and you've already got an accessory artery in the groin that you can then just take for your VA ECMO. Now, what if you're dealing with an alternative access case? Okay, here's a patient I treated in late 2018. That's her distal aorta. Obviously, you can't do a TAVR from down in the femoral artery, so this is one where we went percutaneously from the axillary artery. We were able to get a wire up from the femoral. Don't ask me how I did that, but we did. From the right, it was actually accessible. We then aimed for the wire, and you can see the needle coming in from the right. That circular density that you see there over the fingers, that's my wedding ring as I'm getting percutaneous access. You can see that's what we're fluoroing there. So you can gain access percutaneously to the axillary artery and then put your delivery sheath in from there. Now, if something goes wrong with this kind of case, you can use that arteriotomy for your arterial return cannula. That's a 14 French sheath. You can simply, it's already pre-closed at the beginning of the case. You can simply exchange that for a 15, a 17, whatever size cannula.
Is that 14 French OD outer
ID.
diameter?
Yeah.
ID.
16 ID, 16 OD.
OD. Okay, so a 17 would easily fit.
Would
If
easily
you put
fit
this
on.
in, you could put that in.
You could easily fit
Okay,
in a
fair
17
enough.
French cannula. Exactly. So that's the rare circumstance where you have to do that. We do percutaneous axillary and things relatively rarely. As I showed you, nearly 90+% of the cases are now purely transfemoral. So I just show you that as a potential alternative. Going back to the transfemoral situation, what are some of the complications you need to avoid of transfemoral ECMO cannulation? Well, if you put a 17 or a 19 French in the femoral artery, particularly in smaller individuals or individuals who have some degree of peripheral arterial disease, you're going to lose perfusion to the leg, particularly if you're going to leave them on ECMO support as you leave the cath lab or hybrid room and go up to the intensive care unit. You don't want a dead foot or leg. Saving the patient's life and losing their leg is sometimes a worthwhile bargain, but that's not the optimal goal here. Okay. How do you deal with that? You need a retrograde sheath. You can see the sheath traveling towards the patient's toes there on the right. That is a 7 French braided arrow sheath that is traveling in the other direction down towards the patient's feet, and it's hooked into the arterial return cannula. So blood is basically flowing in that arterial return cannula through the sidearm of that sheath back down that patient's leg. So even if that arterial cannula is completely occlusive, you now have a blood supply from that cannula down the leg so that you don't lose the leg.
I see they're using NIRS because, of course, you on the calf to look at saturation because, of course, you won't get a Doppler pulse,
Correct. It's
No
going to be
pulse.
continuous flow.
continuous flow. But if you use NIRS, you at least know the saturation. We were talking about NIRS yesterday,
we talked
remember?
about this
I'm sorry,
exactly.
please.
No, so it's a fantastic picture. It's become standard procedure now at our institution. If you're placing the cannula, don't take a risk with that leg. Just go ahead and place the antegrade sheath. Make sure that there are no issues there. It is not worth losing the leg to save the patient's life, particularly when a simple solution like this allows you to preserve flow to the leg.
Right, yeah, and I think what you're saying is that right. It's not. If that was the trade-off, life or your leg, yeah, well, life comes first. But right, your point you're trying to make, I think, is that there's no need to lose the foot.
Correct.
So why lose it when you don't have to for a simple solution?
Exactly. Okay. Now, last potential complication of going on VA ECMO as bailout for these patients, differential hypoxemia, okay, sometimes called Harlequin syndrome or north-south syndrome. Keep in mind that with some of these patients, their lungs can get flooded during the process of decompensation, okay? A coronary issue, for example, heart's not pumping well, things are backing up behind the heart, they go into acute pulmonary edema. All of a sudden, it's really not well oxygenated blood that is being delivered from the right to the left side of the heart. Now, oftentimes we have successfully replaced the valve at this point while we're dealing with whatever the complication is. That heart may potentially be ejecting, but it's going to be ejecting through your new valve relatively deoxygenated blood. And that means what the great vessels are seeing up top may well be relatively blue blood. And therefore your brain may not be getting as much perfusion as your lower extremities. That is a suboptimal situation, and yes, I have seen patients develop an anoxic brain injury because of this situation going undetected. While it's bad to lose your leg, it's even worse to lose your brain.
Yes,
Right,
I
yes,
just
right.
presented a case, was it yesterday?
Thursday.
I think Thursday, of a similar situation, and on a 21-year-old.
The key to avoiding this is making sure that you are checking your arterial blood gas at a point that is as distant from the arterial return cannula as possible. So in most of these cases, if the arterial return cannula is in the left femoral artery, you place the radial arc line in the right radial artery. That oxygen saturation, that PO2 is likely what the brain is seeing. So if you're seeing low PO2s over here, that's probably what the brain is seeing, and you need to do something to fix that. And typically the fix for that, there are a number of ways that you can fix this, but probably the simplest and most elegant solution is to simply wire your arterial return cannula and return red blood to the venous circulation up top, so that what's being returned to the right heart is now well perfused oxygenated blood. So that gets transferred to the left, and that ejecting LV then pumps oxygenated blood to the brain. So those are just some of the bailout strategies and considerations that we need to think about. And I think this is very important because TAVR, as we've seen from the data and the change in the federal government's stance on this, is going to diffuse all across the country, all across the community. It is a wonderful technology, and we're all going to be using it. But let's face it, there are going to be that 1% of patients who face significant complications. And what are you going to do with that 1%? You need to be prepared. Typically, when these complications occur, they are devastating. There's going to be severe hemodynamic compromise, and you are going to have to put them on a substantial form of hemodynamic support. By far, in terms of flexibility and ease of use, ECMO is the answer here. It's harder to have a full heart-lung machine in place in a cath lab. Less substantial forms of support may not give you the ability to oxygenate and ventilate the way ECMO does.
Well, it's also very easy
Correct.
to transition from ECMO to full cardiopulmonary bypass.
Correct.
I mean, it's really not, it's a pretty simple thing to do.
Correct. Or step down if you need to if the patient's recovering.
Sure, right, but yeah, right, you have those options.
Options.
Exactly.
It's that nice middle ground that it gives you. It gives you enough time to fully support the patient, fix the underlying problem. If you need to go to the OR and convert to full cardiopulmonary bypass, you can. If you're bridging to an acute recovery, you can step them down very easily to an Impella, a balloon pump, whatever you need to take them up to the unit.
Or leave them on that. And take
Or leave them on
Transporting somebody on an ECMO is a whole lot easier than when they're on full cardiopulmonary bypass.
Yes.
Much easier to do,
Exactly.
clearly.
So ECMO serves as a fantastic bailout under these circumstances. And I think as a community, we're now all going to have to become much more facile and familiar with how to use ECMO as a technology for bailout, since TAVR is going to become so much more widespread. Thank you.
Very good.
Thank
Excellent.
you. Thank you.
Very good. Are there any questions from our studio audience? Oh, there's nobody back there in our studio audience. Our studio audience has abandoned us. Yeah, really, really good. I have one very fast question because I'm going to forget it if I don't, and then I'm going to let Tammy and Kim or Katie ask their questions first. But on the cannulation, I saw that you put in you have your pigtail in the contralateral femoral artery from where you're doing your procedure, your delivery system site, or your dry sheath, I guess that's what it is, a big gore dry sheath or
So
something.
the dry sheath or the Edwards E sheath, depending on which system you're using.
Whichever it is, but your sheath. And then you have your femoral vein with just a line and a wire in it so that you can, or a catheter so you can exchange it and put a catheter in. Some people have told me that they just use the sheath and put a 17 French, I think it's the Medtronic catheter, just right through that sheath and use that. But if you do that, you no longer have the, I'm assuming, the ability to continue with the procedure unless you then reinsert another delivery sheath in the other side. So do you have a preference either way as to which one you think works best?
I prefer to separate them, knowing what my bailout options are and my valve delivery system are, because my goal is, if something happens, I want to be able to at least deliver the valve to take that issue off the table. So to give you another example, there was a case where I had an LV perforation, a wire perforation of the LV. Okay, wire migrated out.
I remember that. Well, and we thought it, and the patient had lousy lungs. Remember, we drew a blood gas off of the pericardial effusion, and it was, the saturation was kind of crummy, and I was like, well, that looks venous. I mean, that's a venous number. But it ended up being the LV. I remember that.
Exactly. So with that LV perforation, if the wire had already migrated out before we had delivered the valve, and I saw the wire and I knew it was in a bad position, it, however, was tamponading the hole at that point. So my thought was, I can pull the wire back and face hemodynamic collapse now, or I can leave the wire where it is, deliver the valve, then I'm only dealing with one problem, not two problems, okay? If I don't deliver the valve, I've now got a patient with severe AS and the inability to perfuse herself and tamponade at the same time. Once I drop the valve, I've taken the valve issue off the table. Now I just need to deal with the hole in the LV. Okay, which is much easier because we tapped the pericardium, we waited to see if it auto-tamponaded, it didn't. We took her to the OR, surgeon placed one stitch. Didn't even have to go on bypass to do this.
Right, sure. Yeah, you would normally not have to do, you shouldn't have to do that for that problem, but did he do a full sternotomy, or did he? He did, yes. They bought a sternotomy anyway. Hey, but I'm glad it wasn't a redo.
No, exactly.
Okay, so they, there's always a how does that go? A shiny cloud. How does that saying go?
Silver lining.
A silver. That's right. Silver lining. That's right. The cloud. Thank you. I appreciate it. Okay, I'm gonna let Kim. I keep calling you Kimberly.
I know, today.
I'm going to keep letting Katie and Tammy ask their questions first.
You go ahead.
Okay, so my interest is in the actual care of the patient. So once the patient leaves the cath lab, or what can you expect for the nursing staff?
Absolutely, that's a great question, and that's something that's evolved over time. When we first started doing this back in the early 2010s, 2011 or so, these patients were receiving 24 French sheaths. That original Sapien delivery system was 24 French, huge arteriotomies, a lot of vascular complications. Everyone was going to the CCU. They'd spend days in the hospital before they left. We didn't really know what the hemodynamic changes would be after valve replacement. We kind of relived the original era of surgical valve replacement 50 years prior. The blood pressure goes up, the blood pressure goes down, we have no idea what's happening, it's a roller coaster. All of this we have to manage in the CCU. A decade later, nearly a decade later, we now know how this goes. And for the most part, with these lower caliber delivery systems, patients are going home the next day. Okay. So rather than using the resources of an intensive care unit for relatively well patients, we simply go from the cath lab to the PACU, from there to a step-down unit. My goal is by that evening, the patient should be up in a chair. By the next day, they should be walking around. By the latter half of that day, as long as they can brush their teeth, go to the bathroom, and walk, they can go home.
Wow,
Okay.
that's nice.
Exactly. So it's much less intensive now in terms of the care of the patient. In terms of the hemodynamic piece, I do want to address that. For a long time, when the valve is stenotic, the LV is generating a supranormal pressure to get blood through that narrowed orifice. When we suddenly replace the valve, no one tells the LV you can stop generating that supranormal pressure. So a lot of these patients are markedly hypertensive immediately after the procedure. So you do need to be careful about the blood pressure in that first 24 hours post. We've learned kind of the pattern here. There's, at about 24 to 36 hours, there's a baroreceptor response whereby the pressure, the body realizes, hey, wait a minute, what's all this new blood flow? And the blood pressure comes down. So you have to be careful. You need to bring the pressure down, but don't overdo it, because once they adapt, you'll floor them otherwise.
So what kind of parameters do you look for in blood pressure reduction post TAVR?
Typically, I want to see them around 130 to 140 post TAVR. And oftentimes what we'll use are short-acting agents, things like nicardipine drips, rather than giving them a bunch of long-acting orals, because when they do adapt, I don't want those orals still acting and dropping their
'cause you
pressure
can't take
too
them
low.
back.
Exactly.
Nice.
Okay.
And then when you have these big complications, and is that typically right away when you're in, like they've happened?
Yes, typically.
They've happened right away?
Yes, typically if you're having one of these devastating complications, right away. There's hemodynamic collapse.
So if you were to tell me, or if someone were to tell me, Katie, you're admitting a TAVR to the ICU, then I can expect that something terrible went wrong?
Yes and no. I wouldn't say that. Yes, the ones where there are devastating complications, they're going to go to the ICU. Occasionally, I will still send a patient to the ICU if I'm worried about, is that groin still oozing, bleeding, and I want those Q15-minute checks on that groin to make sure it doesn't well up into a retroperitoneal hematoma or something like that. But for the most part, well above 90% of these patients are going to be going the less invasive route.
Okay.
All right, I have a few questions. Are we
it
using
just
this
me?
or
Is
just
it
for
just
my-
me?
No, just you.
Oh, was it
Because
my
your
position?
microphone's on one side, so
I'm
when you turn
sorry.
your head,
Oh,
they can't hear you. So that's
it's like
okay.
differential
I'll
hypoxemia.
go that way.
It's
It is.
Right? It totally
This is
is.
left-right syndrome, though.
Okay, oh, that's pretty funny. All
Okay,
right.
I just have a couple questions. First off, the perivalvular leaks, what do you do about those? Do those patients have to require surgery? I mean, is there a certain amount of that can be tolerated and you think, well, it's still a success?
Absolutely, that's a great question. And as we said, that's one of the original Achilles heels of TAVR as compared to surgical AVR. What the data has shown us is that mild or less paravalvular leak seems to have no long-term consequence for these patients. However, once you get into what's echocardiographically deemed moderate or greater paravalvular leak, it does affect the long-term survival of these patients. Now, acute severe paravalvular leak, let's say we deploy the valve, it's canted, or we miss the annulus, something like that, and you've just got a wide open AI situation. That's hemodynamic collapse.
Yeah.
And at that point, what you need to do is actually deliver a second valve. Okay, so that tends to be the bailout there. You put a valve within a valve under those circumstances and try to seal that original valve. But you may need hemodynamic support in the interim because it's going to take you about 10 to 15 minutes to get that second valve up there. And that's where the ECMO comes in. Now, I know AI in the setting of ECMO, you're potentially flooding that LV. However, typically this is a short duration. And that's also part of why I prefer to maintain the access site separately, to go back to the other question that was mentioned. If you can support from one side and deliver from the other, you have the ability to take care of the whole situation.
Okay, that actually leads right into your solution, leads right into my next question. As far as what do we, I know it's early to know, but what I understand the plan if you have to have a replacement valve, like if you're doing this on a younger patient that's going to outlive their valve, it's just a valve that's placed inside of a valve. Is that correct?
Correct. That gets to the durability issue. And we mentioned, for example, partner 3, the follow-up is 10 years here, because the low-risk patients tend to be a younger subset.
Right.
So if you're getting a TAVR at age 65, hopefully you're going to be around 10 years later.
Right.
Okay. We have not yet rigorously studied TAVR in TAVR. What has been rigorously studied is TAVR in prior surgical AVR. Okay. We know that that is a safe and effective procedure. So all of these patients that have gotten surgical AVRs that after a decade, they've gotten the value of that valve, the valve is degenerate, restenotic, et cetera. It is a relatively simple procedure to do what's called a valve-in-valve TAVR there. You simply place the TAVR prosthesis within the surgical prosthesis, and the patients do quite well. There is going to be a trial coming now for TAVR in TAVR. That is not yet an FDA-approved situation. And we have not yet seen a large number of these because happily, even the original cohort of valves that we replaced a decade ago are still doing relatively well. We've got data in Europe out to about 8 years now, in the US about 7 years, where the durability of the original valves is quite good. But you're absolutely right. We're not far from that decade or so point where some of these valves are going to start coming back dysfunctional. Have we done off-label TAVR and TAVR? Yes. It is feasible, it is doable. The next phase is to rigorously study that process.
Okay, and I just have one more question. So talking about kind of the surgical team support, what is the role that you think the surgeon has during the procedure? I know some places that, surgeons in the room, some places they're just available. I'm assuming it's a requirement that a surgeon is at least within a certain proximity that they could respond. And then if you could also expand on as far as perfusion support or circulatory support, depending on the hospital setup, is it a requirement that those people be in-house for now that we're going out to these community centers?
I'll answer each of those questions in turn. The surgical piece as to what the role of the surgeon is or should be, you're right, that varies by individual institution, individual heart team. The experience that I've had working with my surgical colleagues is we are hand in hand, okay? As I mentioned, Dr. Nguyen is my surgical partner, Dr. Estrella. We're always scrubbed in together, and we are doing the procedure together. And that is really the spirit. If you look at the language of the NCD, it says that the surgeon should be a full participant in the procedure as well, not just sitting in the control room, et cetera. And that we've really kind of lived the spirit of the heart team in that regard. And that collaboration is magical because now we both feel very invested in the well-being of this patient. When we're making decisions as to whether a patient should have a TAVR, now that we're in this low-risk era and every patient potentially can get a TAVR, we can sit down together and talk about what is the right thing for this patient. Should they have a TAVR? Should they have a surgical AVR? If you're a 60-year-old with a bicuspid valve and an ascending aneurysm, I'm sending that patient for surgery every time, okay, because that's the definitive solution for their overall pathology. I do think that different places are going to do it differently, and largely what's going to happen over time is I think interventional cardiology and CT surgery are now becoming much, much closer. I feel closer to my CT surgery colleagues than I do to my general cardiology colleagues.
Well, that's exactly the point that I was hoping you would get at is it's important to keep this as a partnership just from the standpoint of what's best for the patient, because if it's not, then it can definitely become a divisive thing.
Correct.
I need my surgeries, you want your TAVRs, etc.
Right, and that is absolutely what we are hoping to avoid. There has been discussion. I sit on the SCAI Structural Heart Committee at the SCAI meeting this May. That's exactly what we talked about. As we proceed into this low-risk era, how do we avoid turning it into a rivalry rather than what it has been, which is this collaborative effort to choose what is best for the patient. And building that heart team where surgeon and IC work hand in hand and are scrubbed in together and are doing all of this together, I think really facilitates exactly the vision that you're describing.
Right. Okay.
Now, the second part of your question, the bailout piece, it is not, as far as I can tell, per the NCD, a requirement that one have ECMO or any specific piece of hemodynamic support available. That is really left up to the individual institution and the individual heart team to choose how they are going to bail out under dire circumstances. And that really is kind of the frontier here, and that's why I brought it up in this talk. As TAVR disperses into the community, we really need to think about how we're going to do this, because we need a bailout option. As I said, ECMO, I think, is that perfect intermediate option where it's invasive enough and provides enough support to get your patient through the acute complication, but is easy enough to deploy quickly if you need to transport, small enough, safe enough to transport effectively and easily under those circumstances. So I think we may see a substantial growth in ECMO with the dispersion of TAVR.
Okay, thank you.
Well, yeah, but that brings up, and thank you. Those were really good questions from both of you, I thought, and I really appreciated the answers because they were thoughtful questions. You know, I'm going to be perhaps a little provocative, and you know, I know that's kind of unusual, you know, for me. But I recently gave a presentation right here on TAVR coverage. And, you know, I tend to be somewhat of a financial pragmatist, and I think we all have to be. And though I appreciate very, very much your feelings that you want that collaboration with the surgeon, having them there, the procedure, et cetera, you know, there's a part of me that questions the wisdom of that. I think that, you know, you look at, of course, the one extreme being Germany that has zero surgical coverage at all for their TAVR procedures. And though I value surgeons also, they give us all of our work, right? You do too, though. They don't give us all of it, they give us a lot of our work, okay, going on pump. However, is it really the best thing? Is it really necessary? Is it really that beneficial? Unless you plan on immediately opening the chest and doing some kind of big surgical procedure. Most interventional cardiologists that I know, if not all, can easily put a patient on ECMO. You don't need a heart surgeon to do that. If you have a peripheral vascular complication, perhaps you will need a vascular surgeon to consult. You can always control the bleeding until somebody were able to get there. And that's going to just reduce the cost. It's not going to reduce the care. Although I love Dr. Wynn as well. I think he's a Dr. Estrella, but Dr. Wynn, as far as I'm concerned, both of them are absolutely first-class surgeons and great at what they do. But why are we adding this cost to a procedure where if there is a problem, their wire skills, their catheter skills, their ability to manage the situation without a knife and a saw and a pump, it really doesn't exist?
Well, I wouldn't say that it doesn't exist. Dr. Nguyen, for example, did a fellowship in percutaneous.
Okay, very rarely.
There are some surgeons, and that's what I mentioned.
Very
the
rarely
disciplines in terms of the training over time are going to become closer. More and more surgeons are going to be learning the wire and catheter skills. And I think more and more ICs need to learn some surgical skills. We may need to learn how to cut down to a femoral artery. Having that combination of skills.
I don't think that's going to happen in our lifetime.
True.
Our practice lifetime, certainly. But go ahead, I'm sorry.
But you're absolutely correct. If we don't choose that sort of avenue where the two disciplines come closer together, I fear that they are going to go in divergent directions, and sadly cost is what drives a lot of what we do. And I hope that that does not lead us into an era where everyone's offering a different brand of TAVR.
Well, I would hope so too, but I think that, you know, in my sort of view of this from from both a quality and economic perspective, looking at both of those things, though it feels good to have a heart surgeon right there while you're doing the procedure, I see it. I don't see the clinical benefit more so than I see. I think if you had some type of a meeting, you know, a committee of some sort that reviewed the procedures jointly and said this is what our option is, and any debate about how best to manage that patient would take place there. Perhaps having a heart surgeon who may have, just from physically seeing a lot of this anatomy, might have some perspective that could perhaps be of value to any operator of the catheter delivery system and the device in terms of its implantation and all of that kind of thing. But you know, I mean, I just watched for the first time, didn't have any idea what the procedure was until I saw 3 of them last Monday. You were there for those basilica procedures. So, and that's where they go in and they use basically already existing devices, puncture a hole. And the reason for doing the basilica procedure is that if the valve leaf of the coronary ostia rides low, I guess particularly the left coronary, rides low, and when they implant the valve, there is a risk that the native leaflet or the
Bioprosthetic leaflet.
the bioprosthetic leaflet will impede on it, will open up and cover it, like what you saw with that piece of calcium, only this wouldn't be something you can easily fix. You put this wire in and you use a bovie and you energize it so it punctures a hole through the leaflet, and then you catch it with a snare and pull it through the central orifice of the valve, and then energize the wire again as you're pulling up, you know, withdrawing it from the patient, and it essentially cuts the leaflet in 2 and
Lacerates
opens it up. Yeah, lacerates it. And then so that when the valve gets pushed to the side, that leaflet, if it does open up that direction and not just crunches up, will open like I guess a basilica.
Correct.
So therein lies the name. I was like, who's Dr. Basilica? I had to figure it all out, okay? So that's pretty creative. But I think that the Europeans probably have, you know, the STS, and I certainly respect why they did what they did, which was, you know, in order with CMS, you know, the lobbying that if a surgeon is not there present on site during the procedure, scrubbed in, you don't get paid for it. I think the private insurers are going to eventually recognize that that is really necessary, and that's, I think, going to go away. It doesn't mean that I think, however, that collaboration through committee or whatever review process you have should go away, and the collaboration should go away. That I agree with you 100%.
And that remains a required. The original CMS mandate indicated that there must be a valve conference. So
That's what I was trying to say, conference.
Oh, okay.
before any of these patients can proceed with TAVR, there must be a multidisciplinary conference
Right.
with interventional cardiology, cardiothoracic surgery, and all the other relevant disciplines present that review each of these cases and approve them as TAVR versus surgical AVR. And that is something that remains robust at our institution. And I agree with you, you cannot underestimate the importance of that multidisciplinary conference. That is where the team really has to come together and choose what is best for the patient. And really that was the impetus for the start of my career. I remember as a fellow I was once told, invent valve conference. So I did.
Yeah.
Because no one knew how to run that kind of conference at that time.
Well, I'll tell you this, and I think that should stay in place.
Correct.
That I believe in, because it has no cost associated with it, no real
Correct.
cost, but it has tremendous benefit, or very low cost, if you want to say that if there were employees of the institution, yes, there's a cost associated with it, but it's low compared to benefit. But what disappoints me about these things, and it's not your fault, it's not the institution's fault, it's not the surgeon's fault, it's our fault, is that there's never perfusion representation about how do we manage the patient if there does need to be a bailout, because I think we have some unique skills and understanding of the just the logistics and the dynamics of everything happening with the patient in terms of cannulation and so forth, and being on board with it. Nor is there any post-op ICU nursing in the ICU that could also potentially be contributing to those valve conferences. And so that disappoints me.
From our perspective, we do have the CCU nursing
That's
staff involved.
great.
So CCU
That's
nursing
awesome.
leadership is involved in our valve conference. You're right, I haven't had perfusion.
And that's not y'all's fault. That ultimately ends up being our fault. You know, we don't really find ourselves involved. And I think that
The invitation's open though.
thank you very much. I think that our profession has sort of evolved in that direction, that
It has.
we know very little about the patient. They get consulted, and I've been on multiple open heart consults where I've just stood there and just was visiting with the surgeon, and he gives his patient a consult. Okay, we're gonna take you to the operating room, we're gonna get you to sleep, we're gonna clean you up real good, we're gonna make an incision, and we're gonna open your breastbone. They never say we're gonna saw it open, or whatever,
Let's say
hack it
that.
apart. They
Right,
never
right.
say that. And then we're going to put you on the heart-lung machine. We're going to do the operation. We're going to wean you off the heart-lung machine, and then close you up and send you to the ICU. They never ask who runs that heart-lung machine and what the hell is it? And what does it really do? What are you really going to do to me? It's just breezed over because those are things that if you were to really give a true informed consent, it would start at 6 in the morning and end the next morning when you went to go do the case.
Right.
So it's limited. But we're just not involved. So we don't really know much about the patient until they get in there. Then we look at their chart. We get the basic information that we need to have. We know nothing about their family dynamic, nothing about what their interests in life are, we don't know them. They're just there. We go on pump, we do the procedure, we come off pump, patient comes off pump looking great. Oh, we tap ourselves on the back. You did such a great job today. They close them up. We kind of go with them to the ICU. We drop them off, and we leave.
Well, I think
Never see them again.
I think that is very much how your perfusion practice is set up in most of the hospitals. Now, some of the larger hospitals that have very large teams often have someone who does follow-up, who might pre-op them, but on the smaller teams, it's a staffing thing, I would say, for the most part. Now, that doesn't mean your perfusion team couldn't set it up where they're, looking at the patient at least the day before, or, reading about them, those kinds of things.
But surgeons would be horrified if we went and visited the patient before they were going to operate them. Anesthesia does. The surgeon does.
I don't agree with that, because in my last place of employment, if it was required where we needed to do a TEG, which we often did, we went and visited the patient alone in the cath lab, introduced ourselves.
I would say that's rare.
But
I would say it's rare. It does exist, and I'll grant you that. But I
agree.
think it's pretty rare.
I agree. You're right. A lot of times it's once they roll out the operating room door, we're like, see ya, it was fun.
Right.
And that's it.
We don't know whether they had a stroke. We don't know whether they went into renal failure. We don't know if their post-op course was simple and beautiful or complicated as hell or whatever.
Well, that's a shortcoming in our community.
Yes, that's what I think that was my point.
I mean, but that's more on us than it is on other people.
Okay, so now that we've debated that, self-expanding versus balloon expanding. Because I understand that I don't know if it's related to self-expanding or balloon expanding, but heart block seems to be higher, and I didn't see that in the data, but that doesn't mean it was not there. Just might not have been relevant to this talk. Is heart block a need for permanent pacemaker more common in self-expanding versus balloon expanding, or is it because of something else in the design of the prosthesis?
Based on the data, there has been a greater need for permanent pacing with the self-expanding prosthesis as compared to the balloon expandable prosthesis. I do think part of it has to do with the frame of the self-expanding prosthesis. It is a nitinol frame that continues to expand and therefore continues to exert pressure on the LVOT. But part of it is also under our control. It has to do with the depth of implant. If you are implanting that valve very deep in the left ventricular outflow tract, your likelihood of conduction abnormalities is substantially higher. If you implant at a lower depth, much higher up, the rates of conduction abnormalities are lower. So there are institutions that are primarily self-expanding users who see relatively low rates between 5 and 10% of pacemaker use. However, broadly, when you look at it, yes, there is a difference. With the balloon expandable platform, pacemaker rates are about 4 or 5%, whereas it's about 10 to 15% with the self-expanding.
Much higher.
Yeah.
Which
Much
is
higher.
absolutely.
Is there any way to know where the AV node actually is?
No.
So there's no way
Not that I know of.
So there's no way to say, you know, we need to be above this threshold when you put a valve in.
No, we have certain ideas of where we want to implant, not just based on conduction issues, but improving the hemodynamics. The higher we place the valve, while still sealing the annulus, the better the hemodynamics, whether we're talking about a self-expanding or a balloon expandable prosthesis. Simply because the lower you seat that valve, the more constrained you are by the annulus, the lower is the effective orifice area of the prosthesis.
Sure.
The higher you can sit it up, the better orifice area you get.
Sure. No, that makes that makes sense. I mean, back in the early days, I mean, when we did, much earlier days, having heart blocks associated with isolated aortic valve, surgical, of course, only was really pretty common.
Yeah.
And it was just from swelling.
Right, it's the edema
Our
around there.
techniques were just not, that good as they are now. Because now surgically, it's not that common. It's not zero, but it's not very common.
Correct.
I noticed that patients not offered valve for other reasons, that were not offered TAVR. How many of those are there of patients who are not offered TAVR for any other reason?
As in not offered any form of aortic valve replacement or
TAVR.
referred instead for surgical AVR in place of TAVR?
Surgical AVR. No, right. Referred for surgical versus TAVR.
Yeah, and we're seeing a lot more of those now in this era of the low-risk patients. The patients that I think are better served by surgery are this younger cohort of patients. If you are, for example, less than about 55 years of age, let's say, and that's where the data with mechanical surgical valves has shown the greatest benefit. Potentially, if you're in your 40s or 50s, durability really becomes a substantial issue.
Yes.
Yes, of
And
course.
a mechanical valve is what is going to provide you with the greatest durability in terms of the prosthesis. So there is a survival advantage at age 55 years or younger to go for a mechanical aortic valve. Okay. After 55, that survival advantage is less available. So once we get into the 60s and so forth, it becomes a question of surgical bioprosthetic versus transcatheter bioprosthetic. We don't yet know what the durability comparison between those two will be. Not enough time has passed to have that durability data. We expect, based on what we know at this point, that they will be roughly analogous. To your question earlier, we do know what TAVR in SAVR looks like. We know that's safe and effective. We do not as yet know what TAVR in TAVR looks like. Presumably it will be safe and effective, but we have no real data on that. So yes, in a 62-year-old with very few comorbidities, they may consider surgical aortic valve replacement, thinking a decade from now when that prosthesis fails, I'll have my cardiologist do a TAVR within the prior SAVR. That's a well-proven commodity at this point.
Yeah, I mean that's what I would be thinking. I would be thinking that, but some things you've said. You know, I've historically not been on the TAVR train, and I think I've so far been left at the station. I mean, I think that I've been, you know, I may have not been right about this one, and I'll tell you why with the next couple of questions. But go ahead, you were going to say something.
The data, though, when you look at the data that we presented, TAVR is potentially superior even among this
Well, that's
young,
what got my
healthy
attention.
population.
Yeah.
So if you're a 62-year-old and you're thinking, I could have a stroke at surgery, I could have one at TAVR as well, but the risk is lower. And remember, we're talking about 62-year-olds. These are people who are truly in their prime. Okay, most of these people are still working. They're in that point in their life where they have enough life experience that they can, whatever they do, they're doing it very well. These are the patients where you can't afford to have a complication.
Yes.
Minimizing things like strokes and so forth in this population is very, very important.
And it's the Achilles heel. It is, stroke is the Achilles heel almost of everything that we do. And stroke mitigation is, I mean, like I think that we've got to get better at it for everything, including just standard going on pump, cardiopulmonary bypass, putting the aortic cross clamp on, shower of, you know, gradu, as we call it in Louisiana, or atheroma, or whatever else gets flaked off, removing it, more gets flaked off, what got trapped under the clamp that just crushed it, and there's an event, and it's, you know, stroke is devastating, and it doesn't even have to be a completely debilitating stroke.
No.
It could just be the nuance of Uncle Joe just isn't the same.
Same.
Right.
Like I said, a lot of these people are in the prime of their careers, and potentially you take that away from them at that point. And apart from stroke, there's a mortality advantage as well. So if I'm
I
a
saw that.
well-informed patient, even at that young age, I may be thinking I'd rather have a TAVR than have a SAVR simply because it's a lower risk procedure for me. And the rate at which the technology is progressing, we will probably learn that TAVR and TAVR is possible over time. I don't know that that's going to happen, but I don't see why that won't be possible given the successes we've seen in the technology over the last decade.
Yeah, and I think that this is, am I interrupting? Do you need to say, do you have a question? And I think that you bring up so many good points, because from a professional, selfish professional perspective, SAVR is something that is a bit more of a benefit to me, because you need to go on pump. Nobody's going to do an off pump at AVR. Never going to happen.
Correct.
Okay. However, and I think this is how we as a profession will survive, and I say this to my colleagues out there as well, partnering with you for the ECMO support, having, you know, you have to reinvent yourself, and becoming that, having that piece associated to these procedures, in my, again, going full circle from what I started this whole conversation off with, makes much more sense to me, and providing him the circulatory support he needs that he can do without necessarily having the surgeon's capabilities there, because there's nothing they can do at that moment other than, I guess, help you put the patient on ECMO, but you could do that all by yourself. That's kind of how I feel.
Well, I think it has to do with an evolution. You have to grow, you know, as technology and techniques change. And I think that's the point that Dr. Balan is making, is that maybe you don't necessarily agree that the surgeon needs to be, you know, scrubbed in and in the room, but this is a part of the surgery and interventional cardiology's evolution of how they're going to become more of a collaborative team. And I think especially in the early stage of this, it's very important that they are developing this road together. You know?
Good point. Very good point. But, you know, you can't ever, you know, I mean, I try really hard, and I think all of us do, you know, try really hard to not let self-interest interfere with our best decisions.
Sure.
But sometimes that's really hard to do. So yeah, I'm telling you, I'm just being, you know what, I'm being provocative and I'm being honest about things, and that's just a reality. We have to work at that.
But if you broaden that out, though, what is absolutely necessary as TAVR moves out into the community? What's absolutely necessary to have in a center to make it a successful program?
I think the key things are this collaboration between surgery and interventional cardiology. I do think that there has to be some bailout piece that is thought out and well planned ahead of time, because you don't want to figure that out when things are going wrong.
Right.
And then the third piece is the support piece from the CCU nursing standpoint, being able to have the social infrastructure to get these patients in and out of the hospital. These are patients that live their lives in an outpatient setting. They come in for an acute procedure, and then we have to transition them back out to their outpatient lives. And sometimes that, many of these patients are older and frail, and they're walking around they're hobbling around with a walker and so forth. They need physical therapy, things like that. All of those kinds of components are part of this multidisciplinary team that is necessary to build a successful program.
Very good points. Something that struck me on your numbers, and I only have two quick questions left. The first one is kind of just sort of a side question, but you did 38 plus or minus 38,000 TAVRs in 2016 at between 500 or 600 individual places. But in the entirety of 2016, actually, take that back, not 2012, we did 35,000 isolated surgical AVRs. Now, some of that can be attributed to the 38,000, that some of those patients were non-surgical candidates and therefore didn't get put into that arm. But I believe, and I may be wrong, but I believe that isolated aortic valve, I think isolated aortic stenosis historically has been underdiagnosed and treated in the past, or those surgical volumes would have been much, much, much higher.
Correct. I agree with you. There is a lot of undetected aortic stenosis out there, because this is a disease that is slowly progressive. That is the natural history of this disease. People get older, they feel like they're slowing down, and they think, I'm just getting older and slowing down. Unfortunately, many people don't have regular access to health care. No one's listening with the stethoscope necessarily. No one hears the murmur. Then all of a sudden, they end up in an emergency room somewhere in respiratory distress, and that's when it's picked up. And by then, you're already too far down this road.
Yeah, your mortality benefit isn't there once you've gotten to that point.
Yeah.
In fact, that's been looked at both surgically and with the TAVR literature. Once you get to an STS score above 15, it portends not only poor outcome at surgical AVR, potentially portends poor outcome at TAVR as well.
But having the TAVR would probably at least, I think a lot of those patients probably improve quality of life. Maybe
Yes.
not duration, but
Right.
quality.
Might not extend their life, but it improve what they have left.
Looking at the cohort B data from the original partner trial, we will extend life. If you can bail a lot of these patients out. And I've done a lot of, I do a lot of the very high risk
Yes,
procedures, and yes, it's a lot of those patients.
seemingly
that-
only.
Sadly, yes. I wish it were better, but yes, I do kind of specialize in the high risk. I do think that we can continue to bail out a lot of these patients, but among that population, the morbidity and mortality is going to be higher, simply because they're coming to the procedure at a much higher risk level.
Sure, absolutely. Okay, my last question is regarding the stroke, since I had talked about that being such a huge problem, because you can have the type 1 stroke, that what we all understand to be a stroke, where it's obvious, and then of course the type 2 stroke, which is the diffusion weighted MRI and various events that occurred that we believe have long-term consequence potentially, that are just not seen at the moment. And that's pretty high, I think, in both SAVR and TAVR. I mean, type 2 stroke is very common in any intervention like
Correct.
this. So it's not isolated to TAVR that it's the, it's the boogeyman problem. However, with the smaller delivery systems and the potential that you showed of going in the axillary artery for the implantation, when I watch the TAVRs done and I see that big valve and delivery system, albeit smaller than it used to be, going up and making that turn in the arch and all the way along that surface, we know it's a chisel and it's chipping away whatever, and it just can't be helped unless we get to the point where we have autonomous catheters that can stay central lumen through some type of fancy computer system and drive itself around and not bang against the wall. But if you came in through the axillary, through the innominate and down, that seems like so much more anatomically suitable. What are your thoughts on that?
The data actually does not bear that out. The stroke rate's higher with transaxillary.
Really?
Yes. Particularly the delivery from the left is actually much more anatomically feasible, because when you come from the right, you kind of have to make this sort of bend into
Yeah, I can see
the
that.
annulus.
This
Whereas
makes more
from
sense.
Here, you can curl in nicely.
You're at least
to the
right. You're at least sort of on
You're-
Same plan.
on a transverse plane
Yeah.
coming
Correct.
into the arch.
Which means you then cross all the head vessels at a very proximal location
Yes.
with your delivery system. And delivering that sheath from the axillary, this was a sheath that was designed for the femoral artery. It doesn't move as well in the axillary position. So
Okay.
I do think that we end up just scraping off more stuff
Really.
from the axillary than
Mm-hmm.
I've seen rates as high as 6%. from the
That's high.
axillary. Yeah.
That's very high. Yeah.
As compared to the data that we just saw.
But of course,
where we're
surgical
less than
AVR stroke
2%.
rate is 5 to 7. I mean, it's high.
But
It's
with
not low.
transfemoral TAVR, we're talking less than 2%. So,
That's a good point. That's a very good point. So, of course, we need to bring you back, and maybe you could find a colleague that would like to participate as well to discuss cerebral embolic protection and how we do that. And maybe we won't say it on the air because I think somebody will take our idea, but we need to work on that and maybe even show our own data, which I think would be really cool to do.
yes.
And but don't tell anybody.
Yeah, the important point that you bring up is there are devices now in the realm of cerebral embolic protection for TAVR. The Sentinel device is FDA approved for this. The TriGuard device has completed its trial and awaiting FDA approval. I don't think we know what those trial data are at this point. Basically, these are devices that cover the arch vessels and try to catch some of the debris that's going north during the procedure. And yes, while the original trial that looked at Sentinel didn't quite meet its endpoint, there were a lot of facets to that data that seemed to indicate a trend towards benefit. And a lot of the registry data that has been accumulated over time seems to indicate fewer cerebral embolic events with the use of cerebral embolic protection. So I do think that that's going to become the standard of care with TAVR. I now use the Sentinel routinely for my TAVRs unless there's some anatomical contraindication to using it. And I do think that is part of what has helped drive down some of the stroke rates. We were allowed to use Sentinel towards the tail end of PARTNER 3. So,
And that's a whole new industry that was launched
correct.
as as a result of the concerns over TAVR and stroke. But I think that again, I think surgical AVR has its own Achilles heel. Surgery has its of any sort, even bypass surgery has with it an inherent risk of a neurologic event of some form.
A diagnostic heart cath carries with it.
I've
a
seen
risk
people
of-
stroke from it.
Yes.
It's happened.
Correct.
Absolutely. Well, any final thoughts from our esteemed panel?
No.
No? No and no? Dr. Balan?
Thank you for having me. It was a pleasure.